So my name's Richard. I'm one of the registrars that have been working in aged care in this area for a while. So thanks for coming to chat to me about your agitated patient and getting some advice with that. I suppose from experience, things I've found useful, I suppose some pointers for dealing with that. Firstly, it's probably useful to clarify with the nurse that's rung you regarding the agitated patient exactly what she means by that agitation. So I suppose whether that patient's actually become delusional or paranoid, whether they've started yelling out, behaviour's changed, whether they've become hypersexualised. All those sorts of words are probably more useful than agitation. It helps give you a bit of direction and I suppose it narrows your differentials down as well. Once you've got that a little bit clear in your mind, it's probably useful to kind of put it a little bit into context then. So particularly what's been going on recently for the patient, any changes in environment, any other particular things that they've noticed around that time that might be precipitants. Then I suppose it's useful to add on any other symptoms that's been noticed, so all the things that might accompany the agitation, mood disturbances, sleep disturbances, appetite changes, those kind of other hallmark signs that might be going on and give you some clues as to what's the precipitant kind of been as well. So once you've kind of got that established, it's also important, I suppose, to think about how rapid is this onset. Is this kind of something that's really been chronic, or is this an acute sort of event? So you want to get just a bit of an idea of the time frames as well. Those are the main things, and particularly any changes. So we mentioned that a little bit before, but particularly things with regards to environment or medications. Those are common precipitants in the elderly for that sort of agitated presentation. Then I suppose while you're going through this, you're keeping in mind some of your chief differentials. There's probably only 4 or 5 really. Main ones, on top of your list is always delirium. So, and then keeping in mind that that's a global impairment of function. That's cognition, perception, level of consciousness, all of those things, memory. They're all contribute. They're all affected rather in that instance. And you've got your dementia-related agitation, exacerbation of sort of long-term psychiatric illnesses, and then your kind of medical, I suppose, more physical things, which they're all interlinked. I suppose it's important to remember that delirium is a sort of a combination, really, of predisposing factors with acute precipitants on top of that as well. So what you'll tend to find is you're not really looking for one diagnosis, you're looking for a combination of things. So things that would lower their threshold to that agitation in the beginning, and then other things coming in on top of that, infection, etc. That would, I suppose, tip you over the edge a little bit. Once you kind of thought about that, and often delirium will end up at the top of your list, thinking about precipitants for those things, it's probably useful to divide it up into things inside the head and things outside the head, as a simple way to think of it. So your intracranial pathology would be things like your stroke, neoplasia, epilepsy, seizure-like disorders, any of those things going on inside the brain, and then things outside the body which affect the brain, such as infection or sepsis, metabolic disturbances, medication toxicity, malnutrition, any of those sorts of things which affect the brain's function. Then I suppose you move on and have a think about where you go from here. Investigations. It's obviously important to start with a good physical exam. A lot of elderly patients, when they're either agitated or not, can't really express what exactly is going on. So a good physical exam can often tell you more than a history from the patient. So it's always important to remember things like pain. So move every joint, poke and prod everywhere, start from head to toe and be quite thorough. Your full respiratory, cardiovascular, neurological as best as you can. abdominal and joint exams would all be useful, and you'd often pick up things just from a good thorough physical exam. Obviously, if they're agitated, it can be difficult to do that physical exam, so you might need assistance, or leave that until you've got some of that agitation a little bit under control with other means. Other investigations, then you'd have your standard workup, think about your full blood count, electrolytes, inflammatory markers, think about blood cultures if they're looking septic. Your sort of stock standard blood investigations. Really, it'll be a little bit determined by what your findings are. You'd have to think about imaging, X-rays of your chest, or CT scans of your head, ECGs, those sorts of things can also be useful. Then I suppose other things you can add to your investigations would also be kind of forward-looking investigations, so starting them on pain scales or withdrawal scales, which might give you a bit more information down the future if you're not sure exactly what's going on, but it can be a little bit kind of anticipatory as well. Once you've got those investigations and you have a bit of an idea of where you're heading, then it's obviously you're going to be treating the underlying cause that you found. Whatever that may be, infection, intracranial pathology, and you'd have to fill that out depending on what you find. You'd certainly not be using benzodiazepines as a medication wherever possible, except for the case of withdrawal from benzodiazepines or alcohol. Generally, you'd tend to lean towards your antipsychotic medications, as well as remembering that it's important to think about your behavioural measures as well, so increasing your nursing supervision of the patient, preventing falls, using bed rails, restraints if necessary, obviously with appropriate consent from family or caregivers. And I suppose from there as well, it's arranging appropriate follow-up, so when are you going to see them next, what's the appropriate place for them to be managed? Is it hospital, is it in that same setting that they're already in? And when do you plan to see them next? So just giving those clear instructions to the nursing staff as well. I suppose there's many other things to be said with that, but that's probably a good starting point with the agitated elderly patient.